Hi, this is Tammy McClish. Let's take a look at radiographic critique of lower extremity. Now, once I receive a requisition for the lower extremity, I want to make certain that the requisition is appropriate for the doctor's order. So I want to make sure that if I have a order for a right femur, that the patient is having a problem with the right femur and it's not the left femur. So I want to make sure that it's the appropriate area of the body that I'm going to x-ray and that's the appropriate side of the body that I'm going to x-ray. When you're dealing with procedural codes, which are CPT codes, they're going to be side specific. So if I have an order for a right femur, I want to make sure that I have a CPT code for a right femur. So you need to be very careful that the CPT code and the diagnostic code, which is an ICD-10 code, are appropriate. When I am x-raying a lower extremity, I'm either going to be x-raying the femur, the knee, the tib fib, the ankle, or the foot. So let's go ahead and take a look at lower extremity. Now once I've checked my script and I've checked my requisition, I then go into my radiographic room and I set up for my patient. The very first thing I do is I determine if I'm going to be taking an x-ray at 40 inches or 72. Once I determine that extremities are all performed at 40 inches, I'm going to set my x-ray tube to 40 inches. Now when I'm setting that SID, what I'm going to do is I'm going to take my ruler out of my x-ray tube and I'm going to bring the ruler down to the image receptor at the point where the central ray will cross across the image receptor. So if I have a 40-inch SID, I want to make sure it's 40 inches to the crosshair of the image receptor. After I've done that, I'm going to determine about the size of the patient. So if I have a foot x-ray, I'm going to start my collimation at a 10 by 12. And then once the patient comes in, if I see that they have very large feet, I'm going to ask them, what size shoes do you wear? And that way I will know if I need to increase or decrease my central ray. The other thing I'm going to do is I'm going to center the central ray to the middle of the cassette and keep the central ray in the middle of the cassette. Digital imaging loves to have the central ray in the middle of the cassette. And the other thing that I'm always going to do is I'm going to pull a right or left marker out of my pocket and place it on my image receptor prior to picking up the patient. That way I make sure that I have the appropriate right or left for the image that needs to be examined. Prior to the patient coming in the room, I'm also going to select a radiographic technique that is going to be comparable for the exam that I'm going to x-ray. If you are working with a pediatric patient, you can even go down into the 40 kVp range. But if you're working with an adult or a adolescent, you can make sure that your kVp range for all extremities is between 50 and 65 kVp. We want to have nice detail on our radiographs, so we're going to choose a small focal filament, which is a small focal spot. And then just to make life easy for everyone, let's go ahead and select a 100 MA station. And then our time in milliseconds is going to vary. Now typically for a foot x-ray, I'm looking at about, with digital, 50 kVp, 100 MA at about 2 milliamps per second. And that is with the digital system. Now, I'm going to utilize a grid whenever I'm measuring a body part that is greater than 10 centimeters. For example, if I had a very large gentleman in and he had a very large knee and it was bigger than 10 centimeters, then I would select a grid, which means I need to go above the 65 kVp. I need to go into the 70 to 80 kVp range for a grid. And I'm also going to place that grid into the Bucky tray. So anybody that measures more than 10 centimeters is going to have a grid for their x-ray that has been ordered. Let's go ahead and take a look at AP toes. When a doctor orders toes, they're either going to order a specific digit or they will want toes in general. So if you have a specific digit, make sure that you collimate down to that digit that needs to be radiographed. So if I have a patient in for toe x-rays, what I'm going to do is I'm going to position the patient seated or supine on the table. Their knees are going to be flexed with their feet separated. I'm going to center the toes with the plantar surface against the image receptor. And then I'm going to direct my central ray 10 to 15 degrees posteriorly. And the central ray is going to enter the affected metatarsal phalangeal joint. I'm always going to use a lead marker to indicate the digit of interest, and I will also use a right or left marker dependent upon the side of the patient. When we're evaluating this image, we want to look to make sure that we have the entire digit or digits and a minimum of 1/2 of the affected metatarsal. We don't need the entire metatarsal. If we wanted the entire metatarsal, the doctor would have ordered a foot x-ray. We should have no overlap of the surrounding digits and metatarsals, and we should have sharp cortical margins and bony trabecula. Now, if we're going to position a patient for an oblique of the toe, the way that we position the patient will be different depending if it's the first 3 toes or the last 2 toes. So if I am x-raying a patient for a great toe, second toe, or third toe, I'm going to turn the patient medial. I'm going to have the patient supine or seated on the table. Their knees are going to be flexed with their feet separated. I'm then going to center the toes to the image receptor, and then I'm going to rotate the leg medially until the foot's plantar surface forms an angle of 30 degrees to the image receptor. The central ray is going to be perpendicular to the affected metatarsal phalangeal joint. Once again, I'm going to use a lead marker to indicate the digit of interest, and I'm also going to place a right or left marker in the collimated field. When I'm evaluating the image, I want to make sure that the entire digit and minimum of 1/2 of the affected metatarsals are in the collimated field. I'm going to make sure there is increased concavity on both sides of the shafts of the phalanges and metatarsals, and I want to make sure that I have sharp cortical margin and bony trabecula. And this is only for the great toe, second and third toes. If I am x-raying the fourth and fifth toes, I am going to, once again, have the patient seated supine on the table, knees flexed with the feet separated. I'm going to center the toes to the image receptor, and then I'm going to rotate the leg laterally until the foot's plantar surface forms an angle of 30 degrees to the image receptor. I want to make sure that the central ray is perpendicular to the affected metatarsal phalangeal joint. And I want to make sure that I'm using a lead marker that is specific to the toe that I am x-raying, and I am also using a right or left lead marker. When I'm evaluating the image, I'm going to make sure that the entire digit and the minimum of 1/2 of the affected metatarsals are within the collimated field. I want to make sure there's increased concavity of both sides of the shafts and phalanges and metatarsals. And I want to make sure that there is sharp cortical margins and bony trabecula. When I move on to my lateral toe, once again, if I am x-raying the great second or third toe, I'm going to have the patient lying upon their unaffected side. I'm going to place the support under the affected knee and adjust the patella perpendicular to the table. I'm going to center the toes and adjacent plantar surface to be perpendicular to the image receptor. And then the central ray is going to be perpendicular to the interphalangeal joint for the great toe and perpendicular to the proximal interphalangeal joint for the second and third toes. I'm also going to make sure that I have a lead marker for the digit of interest, and I'm going to make sure that I have a right or left marker indicating the right or left toe. When I'm taking a look at my image, I want to make sure that I have the entire digit and minimum of 1/2 of the affected metatarsal in the collimated field, and I want to make sure that there's sharp cortical margins and bony trabecula. For my lateral on my fourth and fifth toes, I want to make sure that the patient is lying upon the affected side and adjust the leg and foot in the lateral position with the patella perpendicular to the table. I'm going to center the toes and adjust the plantar surface perpendicular to the image receptor. And my central ray is going to be perpendicular to the proximal interphalangeal joint for the fourth and fifth toes. I'm always going to use a lead marker to indicate the digit of interest, and I'm going to place a right or left marker. When I'm evaluating my image, I'm going to make sure the entire digit and minimum of a half of the affected metatarsal are within the collimated field. And I want to make sure that there is sharp cortical margins and bony trabecula. Okay, let's take a look at an AP foot, also known as a dorsal plantar foot. If I have a podiatrist that has ordered a foot x-ray, I'm going to want to find out if the podiatrist would like this patient positioned weight-bearing. Podiatrists like to see a AP foot and a lateral foot weight-bearing. The reason that they like to do this is because they are going to take the film and they are going to trace biomechanical angles on the film. And the best way for them to do this is if the patient is weight-bearing. So if I have a podiatrist, I'm going to put my image receptor down on the floor. I want to make sure that my x-ray tube is 40 inches away from the image receptor. Then I'm going to place the foot that needs to be x-rayed on the plate, and then I'm going to tell the patient to stand normal. When the patient stands normal with the other foot, what it's going to do is it's either going to put the patient where that both feet are straight, or both feet are toed in, or both feet are toed out. Now, if I have a situation where the patient is toed in or toe out, I want to make sure that the foot I'm x-raying is straight, and then they just place their other foot so they feel that they are in a normal standing position. And what it will do is it will show if the foot is going to be a little bit supinated or pronated. So if you have a podiatrist, please try this position and it will work well for you. If you don't have a podiatrist, you can go ahead and place your patient supine or seated on the table, knees flexed with the feet separated. With the foot plantar surface firmly against the image receptor, center the foot and adjust the midline of the foot parallel to the long axis of the image receptor. You want to direct the central ray 10 degrees posteriorly, entering the base of the third metatarsal. Now, if I was in a podiatry office, their x-ray tube is actually flipped. Now, in saying that, that means that in a podiatrist office, the cathode side of the tube is going to be toward the rear foot, and the anode side of the tube is going to be toward the phalanges. So it's a little bit different in podiatry. In radiography, the best way to image a foot would be to flip the patient on the x-ray table and utilize the anode heel effect. So we have the thicker part, which is the rear foot, against the x-ray tube cathode, and the thin part, which are the phalanges, toward the x-ray tube anode. When we're evaluating the image, we want to make sure the entire foot, including the tarsals, metatarsals, and phalanges, are within the collimated field. Make sure there's no rotation with the tarsals superimposed, and make sure there is soft tissue and sharp bony articulation is clearly demonstrated. Here is a medial oblique of the foot. The patient is going to be supine or seated on the table. Knees are going to be flexed with the feet separated. Center the foot to the image receptor. Rotate the leg medial until the foot's plantar surface forms a 30-degree angle to the image receptor. Your central ray is going to be perpendicular to the base of the third metatarsal. With image evaluation, you want to make sure the entire foot, including the tarsals, metatarsals, and phalanges, are within the collimated field. Make sure the third to fifth metatarsals are clear of superimposition. The cuboid should be clearly demonstrated. The base of the fifth metatarsal is seen in profile, and soft tissue and bony trabeculation are clearly demonstrated. Lateral foot. Once again, we need to determine if we are going to be x-raying for a podiatrist or if we are going to be x-raying for a doctor that is not a podiatrist. If we are x-raying for a doctor that is not a podiatrist, we can have the patient position lying upon the affected side. Adjust the leg and foot in the lateral position with the patella perpendicular to the table. Center the foot and adjust the plantar surface perpendicular to the image receptor. And the center ray is going to be perpendicular to the midpoint of the image receptor entering the base of the third metatarsal. Now, most often it's going to be easiest for a patient to put their foot so that it is mediolateral, but sometimes you may need to place a patient that is lateral medial. If you make a change, make sure that you write this change on your image requisition and also on your image. Evaluating the image, make sure the entire foot with 1 inch of the distal tibia and fibula are within the collimated field. Make sure you have a true lateral with tibio-talar joint open. And make sure the distal metatarsals are superimposed. And soft tissue and sharp bony trabeculation are clearly demonstrated. Now here are your weight-bearing views of your AP foot. If a podiatrist is ordering this and they want to make sure that we are taking an image to include the right and left foot, we are going to have the patient standing on the image receptor. Have the patient stand normal. With the plantar surface firmly resting on the image receptor, center the foot and adjust the midline of the foot parallel to the long axis of the image receptor. Your center ray is going to be 15 degrees posterior, entering between the feet at the base of the third metatarsal. When we're looking at the image, we want to make sure that the bilateral feet with soft tissue detail are within the collimated area. We want to make sure we open the tarsal-metatarsal joints with approximately equal spacing of the second and fourth metatarsals, and make sure there is soft tissue, cortical margins, and sharp bony trabeculation are clearly demonstrated. We're also going to place a weight-bearing marker on this image so that the doctor reading the x-rays knows that this is a weight-bearing view. Now here is a lateral weight-bearing view. I'm showing you a couple different ways to perform this x-ray. In the one x-ray, I have the center ray entering medial and going out lateral, but that is not a true weight-bearing lateral. The second image is a true weight-bearing lateral. So we're going to have the patient standing, place the medial portion of the foot against the image receptor, center the foot and adjust the foot so that the entire foot is parallel to the image receptor, direct the center ray to enter at the base of the third metatarsal, mark this weight-bearing. And the best way to do this is to bring the foot that needs to be x-rayed against the cassette, so it's 100% lateral, and then have the patient stand normal with the other foot. When they're doing that, they're either going to supinate or pronate, and the podiatrists like to see that so that they can get their biomechanical angles off of their image. Image evaluation. If you have steps that have a slot that will hold an image receptor, if this is the case, then go ahead and place the image receptor into the slot and have the patient straddle the image receptor. Place the medial side of the foot against the image receptor will allow the patient to bear weight. The entire foot with 1 inch of distal tibia and fibula should be within the collimated field. The dorsum to plantar surface is demonstrated, and the heads of the metatarsals are superimposed. Soft tissue cortical margins and sharp bony trabeculation are clearly demonstrated. Let's move on to ankle. Now, once again, some hospitals are requiring patients to stand if they are not a trauma for an ankle. So if that is the case, then you would want to perform these images with the patient standing up against the upright chest chamber. So the patient is going to be supine or seated on the table with a small support under the knee. Center the ankle to the image receptor. Flex the foot and adjust the ankle with the toes pointed vertically. The center ray is going to be perpendicular to midway between the malleoli. An image evaluation, the distal 1/3 or tibia fibula, lateral and medial malleoli, talus and proximal metatarsals will be within the collimated borders. No rotation with the medial mortis joint open and the lateral mortise joint closed. Soft tissue structures, bony margins, and sharp bony trabeculation are clearly demonstrated. Here is a mortise view. This is the one that most hospitals are requiring for patients that come in for an ankle x-ray. With a mortise view, you are going to have the patient supine or seated on the table. Rotate the leg and long axis of the foot internally 15 to 20 degrees so that the intermalleolar line is parallel to the tabletop. You want to make sure that the center ray is midway between the malleoli. And you want to evaluate your image so that the entire ankle mortise should be open with the distal 1/3 tibia and fibula. The lateral and medial malleolus, talus, and proximal half of the metatarsals are all within the collimated field. You need to open the lateral and medial mortise joint surfaces, and your malleoli should be in profile. Soft tissue structures, bony margins, and sharp bony trabeculation are clearly demonstrated. Here is another oblique of the ankle, but this one is going to be a 45-degree medial oblique. The patient is going to be supine or seated on the table. Rotate the leg and foot 45 degrees medially. The central ray is going to be vertically between the malleoli. When you're looking at the image, the distal 1/3 tibia and fibula, malleoli, talus, calcaneus, and proximal half of the metatarsals are within the collimated field. You need to make sure you open the distal tibiofibular joint, talus, and medial malleolus with no or only minimal overlap. Soft tissue structures, bony margins, and sharp bony trabeculation are clearly demonstrated. Lateral ankle. Have the patient supine. Roll the patient onto the affected side. Flex the ankle to 90-degree angle and adjust the foot in the lateral position. Center the ankle to the image receptor. The central ray will enter vertically through the medial malleoli. When you evaluate the image, make sure the distal 1/3 tibia and fibula with the lateral view of the tarsals, base of the fifth metatarsals, navicular and cuboid are within the collimated field. A true lateral will have no rotation. The distal fibula is superimposed over the proximal half of the tibia. The tibiotalar joint is open, and the sharp bony margins and trabeculation are clearly demonstrated. Here is a calcaneus or an oscalcis view, and this is the plantodorsal or axial view of the calcaneus. Have the patient seated or supine with the leg fully extended. In the first picture, you were seeing that you center the image receptor to the ankle. Have the patient draw the plantar surface of the foot perpendicularly to the image. And the central ray will be 40 degrees to the long axis of the plantar surface of the foot, entering the midline at the level of the base of the third metatarsal. In the second image, if you have the potential to do so, have the patient stand on the X-ray tube image, on the image receptor, and center the central ray at the Achilles tendon. When you're looking at the image, the entire calcaneus from tuberosity to talocalcaneal joint is going to be within the collimated field. There will be no rotation with the sustentaculum tali in profile medially. And sharp bony margins and trabeculation are clearly demonstrated. Here's a lateral view of the calcaneus or oscalcis. The patient is going to be lying on the affected side. Adjust the leg and foot in the lateral position with the patella perpendicular to the table. Center the calcaneus to the image receptor. Adjust 1 to 1.5 inches distal to the medial malleolus, and the central ray is perpendicular to the mid portion of the calcaneus. When you're evaluating your image, the calcaneus is in profile with the talus to the distal tibia and fibula, partial superimposition of the talus, and open talocalcaneal joint, and there are sharp bony margins and trabeculation clearly demonstrated. Here is an AP of the tibia and the fibula. The patient is going to be supine on the table with the leg fully extended. You need to center the leg to the image receptor and adjust the leg to anatomical position with the toes slightly inverted. Both joints should be included on the image. If you are unable to include both joints, then you have to capture one joint on one image, and then you need to take another x-ray of the joint that you did not see in the first image. The center ray is going to be perpendicular to the midshaft of the lower leg. When evaluating the image, the entire tibia and fibula with ankle and knee joints should be within the collimated field. No rotation with the femoral and medial condyles in profile. Slight overlap at both proximal and distal tibio-fibular joints. And soft margin and sharp bony margins and trabeculation are clearly demonstrated. For lateral, tibia, and fibula, have the patient supine on the table and roll them onto the affected side. Center the leg to the image receptor and adjust the leg to a lateral position. Make sure the patella is perpendicular. The center ray will be perpendicular to the midshaft of the lower leg. When you are examining the image, the entire tib-fib with ankle and knee joints will be included within the collimated field. The tibial tuberosity will be in profile. The distal fibula is going to overlap the posterior portion of the tibia, and soft tissue and sharp bony margins and trabeculation are clearly demonstrated. Here is an AP view of the knee. The patient is going to be supine and the leg fully extended. Adjust the patient's body so the pelvis is not rotated. If the knee measures more than 10 centimeters, you definitely want to make sure that you put the image receptor into a bucky tray that has a grid. If the patient's knee is under 10 centimeters in thickness, then it's okay to x-ray knees tabletop. You want to center the knee to the image receptor, and the center ray is centered to ½ inch distal to the apex of the patella. Now, you really need to look at the size of your patient when you are x-raying a knee, because your center ray needs to be parallel to the articular facets, which are in the tibial plateau. So what you need to do is you need to measure the difference from the anterior superior ischial spine, which is the ASIS, to the tabletop to determine the central ray angle. If you have a thin patient, if their thighs are thin and they have a thin buttocks and they measure less than 19 centimeters, your angle should be 3 to 5 degrees caudal. If they have average thighs and buttocks, you will require no central ray angle if your patient measures 19 to 24 centimeters. And if you have a thick thighs and buttocks and the patient measures greater than 24 centimeters, then you need a 3 to 5 degrees cephalic angle. When you evaluate your image, you want to open the femorotibial joint space. There should be no rotation evident by symmetric appearance of the femoral and tibial condyles. The medial half of the fibular head is superimposed by the tibula. The intercondylar eminence is seen, and the soft tissue and sharp bony margins and trabeculation are clearly demonstrated. For a lateral view of the knee, the patient is going to be medial lateral. You want to turn the patient onto the affected side with the knee flexed 20 to 30 degrees. You want to center the knee by placing the image receptor approximately 1 inch distal to the medial condyle. Your central ray is going to be 5 to 7 degrees cephalic, entering the knee joint distal to the medial epicondyle. Image evaluation: the distal femur, proximal tibia and fibula, and patella are in lateral profile of the collimated borders. The patellofemoral and knee joints are open. True lateral with no rotation. Femoral condyles are superimposed. The patella is in profile and the patellofemoral joint is open. Soft tissue and sharp bony margins and trabeculation are clearly demonstrated. Here is a medial oblique of the knee, 45 degree. The patient is supine with the affected knee internally rotated and extended. You want to internally rotate the knee until a 45-degree rotation is achieved and center the knee to the image receptor. The center ray is centered to the mid-joint space, 1/2 inch distal to the apex of the patella. Image evaluation, you want to open your proximal tibiofibular joint, lateral femoral, and tibiocondyles in profile. You want to have the proximal tibiofibular joint open. The tibial lateral condyles are demonstrated. The head and neck of the fibula and half the patella are seen without superimposition. And the soft tissue and sharp bony margins and trabeculation are clearly demonstrated. Here is a lateral oblique of the knee. The patient is supine with the hip of the unaffected side elevated. Extend the affected knee. The knee is externally rotated and the affected knee until 45-degree rotation is achieved and the center of the knee is to the image receptor. The center ray is going to be centered to the mid-joint space, 1/2 inch distal to the apex of the patella. Image evaluation, the medial femoral and tibial condyles are in profile. The proximal fibula is superimposed by the proximal tibia. The medial condyles of the femur and tibia are in profile. Approximately half of the patella should be seen free of superimposition by the femur. And the soft tissue and sharp bony margins and trabeculation are clearly demonstrated. Here are some PA axial views of the knee, also known as tunnel views of the knee. The first image is a Camp Coventry. The patient is going to be prone with their knee flexed 40 to 50 degrees. The center ray is going to be 40 to 50 degrees caudad. In the second image, you are seeing the home blood method, where the patient is going to be kneeling on the table or partially standing. And the center ray is going to be perpendicular to the lower leg to the mid-popliteal crease. When we're evaluating the image, we want to make sure that the intercondylar fossa, femoral condyles, tibial plateaus, and intercondylar eminence are within the collimated borders. There is no rotation evidence by symmetric distal femoral condyles and intercondylar eminence. And there is soft tissue and sharp bony margins and trabeculation are clearly demonstrated. Here is an AP axial, also known as the tunnel view, and we are looking at the intercondylar fossa. The patient is lying on the table with the affected knee flexed 40 to 50 degrees. You are going to center the knee to the image receptor by placing the knee over the image receptor and a positioning box. Placing the positioning box underneath the image receptor will bring the image receptor closer to the knee. You want to make sure the center ray is parallel to the lower leg. You want to center through the knee joint, entering at the level of the patellar apex. Image evaluation, the intercondylar fossa, femoral condyles, tibial plateaus, and intercondylar eminence are within the collimated borders. There is no rotation evidence by symmetrical distal femoral condyles and intercondylar eminence, and soft tissue and sharp bony margins and trabeculation are clearly identified. Here's a patient for an AP weight-bearing knee. This also can be taken with the patient PA. If the patient is PA, then what you're going to need to do is you're going to need to place the patella against the X-ray table and direct the X-ray tube 10 degrees caudad. But for an AP view of the knees, standing, you need to make sure that the patient is standing in their bare feet. You don't want to take this with the patient wearing tennis shoes or any kind of footwear because that can change the height of the knees. With the legs fully extended, adjust the patient's body so the pelvis is not rotated. Center the knees to the image receptor, and then the central ray will be at a midpoint between the knee joints at the level of 1/2 inch distal to the apex of the patella. Image evaluation, the distal femur, proximal tibia and fibula, femorotibial joint spaces and intercondylar fossa are within the collimated field. There's no rotation of both knees, evident by symmetric appearance. The articular facets are in profile, and there is sharp bony trabeculation is clearly demonstrated. You also want to make sure that you put a weight-bearing marker on this view. Here's a PA patella view. The patient is prone with the knee extended. Rotate the knee anterior approximately 5 degrees internally, or as needed to place an imaginary line between the epicondyles parallel to the plane of the image receptor. The central ray will be perpendicular to the central patellar region at the mid-popliteal crease. When we're looking at the image, the knee joint and patella outline throughout the distal femur. There is no rotation. Femoral condyles and intercondylar eminence are centered, and the soft tissue and sharp bony trabeculation are clearly demonstrated. Here's a lateral view of the patella. You want to turn the patient onto the affected side with the knee flexed 5 to 10 degrees. The patellofemoral joint area is centered to the central ray and midline to the image receptor, and the central ray is going to be parallel to the mid-patellofemoral joint. When we're evaluating the image, the patellofemoral joint and femorotibial joint is demonstrated in profile. The patella is in profile and the patellofemoral joint is open. Soft tissue and sharp bony trabeculation are clearly demonstrated. Here is a tangential view of the patella, also called an axial view, also called a merchant bilateral method. Patient is going to be supine with the knees flexed 40 degrees. You're going to place the image receptor on supports against the legs about 12 inches distal to the patella. Center ray is going to be directed 30 degrees caudal from the long axis of the femora. Center ray is going to be to the midpoint between the patella. Image evaluation, tangential view of the patella. Patellofemoral joint space is open, and the soft tissue and sharp bony trabeculation are clearly demonstrated. Here are some more views of the patella. These are tangential, axial views of the patella. Now these can be taken with the patient PA or AP. If the patient is AP, the patient will receive more radiation toward their upper body. If the patient is PA, they will receive less radiation to their upper body. Now the first image you're seeing is called a Settegast view. The second image you're seeing is a Hugston view. And then the last image you're seeing is a Settegast seated of a variation, and that is called the sunrise view. So let's take a look at the prone views. The first one is a Settegast. The patient is prone with the knee flexed 90 degrees. The central ray is 15 to 20 degrees cephalad to the long axis of the knee. In the Hugston view, patient is prone. Knee is flexed between 50 to 60 degrees from full extension. The central ray is 45 degrees cephalic to the long axis of the knee. And in the last view, which is the Settegast seated or sunrise view, the knees are flexed so that the angle formed by the lower leg and the upper leg is greater than 90 degrees. The part is placed to the image receptor against the distal femur, and the central ray is directed to enter through the patellofemoral joint space. Image evaluation, soft tissue structures or patella, distal femur, and proximal lower leg are included in the collimated area, and the patella is seen in the middle of the collimated area and image. Now let's move on to the femur. When we are x-raying the AP and lateral femur, we want to make sure that we are imaging the entire femur to include the proximal and distal femur. We also want to measure the femur, and if the femur is greater than 10 centimeters, then we are going to need to put the image receptor into the bucky. When we are placing the image receptor into the bucky, then we will need to utilize a grid technique, which will be between 70 and 80 kVp. If we are x-raying the patient tabletop and we are using an image receptor without a grid, then we can stay at the 50 to 65 degree kVp range. When we are x-raying an AP distal femur, we want to make sure that the patient is supine with the toes up. Center the affected thigh to the midline of the table. Internally rotate the lower extremity approximately 5 degrees from the mid-femur and distal femur, and 15 degrees for a true AP to include the hip. The central ray is going to be perpendicular to the mid-femur. For the proximal femur, which you see below, the patient is supine with the leg extended and rotated internally 15 to 20 degrees. Central ray is going to be 1 to 2 inches distal to the mid-femoral neck. When we're evaluating the image, we want to make sure that we look at the entire femur, including the hip and knee joint. There is no rotation. Femoral and tibial condyles appear symmetrical in size and shape, and there are fine trabecular markings. Now, if the patient is not a trauma and the patient is able to roll, then it is okay to position the patient for a lateral, proximal and distal in this method. Back in the day, we used to call this a figure 4 lateral. So the patient is going to be lying on the affected side with the knees slightly flexed. We're going to position the part to include the hip joint, rotate the unaffected hip posteriorly to prevent superimposition of the unaffected hip, center the femur to the midline of the table, and both joints should be included. The central ray should be perpendicular to the mid-femur. The images below show the proximal femur. When we're looking at the image, we want to make sure the entire femur, including the hip and knee joint, are on the image receptor. Make sure that we have a true lateral, the femoral condyles appear superimposed, and we have fine trabecular markings. Now, if a patient is a trauma, or if the patient appears to have a fracture, or the patient cannot move the affected leg, then we are going to have the patient in for a crossfire lateral. The top images show the distal femur. The bottom images show the proximal femur, which is called a Danielus-Miller method. In the top, the distal femur, the patient is supine with the level of the greater trochanter elevated to the center of the cassette. Flex the knee and hip of the unaffected side if possible. Elevate and rest on a suitable support the affected knee. Adjust the pelvis to the supine's position. Unless contraindicated, internally rotate the lower extremity approximately 5 degrees if you're imaging the mid-femur and distal femur, and 15 degrees if you're imaging the hip. Direct the central ray perpendicular to the mid-image receptor. On the bottom images, patient is supine with the lever of the greater trochanter elevated to the center of the cassette. I do recommend using a gridded cassette because you're going to be penetrating through the femoral neck. Flex the unaffected knee and hip and provide support. Rotate the affected leg internally 15 degrees unless possible hip fracture is suspected. Place a vertical grid image receptor against the side just superior to the iliac crest with the plane of the image receptor perpendicular to the central ray. So your central ray should be perpendicular to the femoral neck and image receptor. Image evaluation, you want to have the entire femur including the hip and if possible the knee joints. True lateral, femoral condyles appear superimposed, and you have fine trabecular markings. Pediatrics, lower limb, AP and lateral. In the AP, the child should be supine, include the entire limb, shield over the pelvic area, and immobilize the arm and unaffected leg with a sandbag. The central ray is going to be perpendicular to the mid-limb. In the lateral view, make sure the patient is semi-supine, include the entire limb, shield over the pelvic area, Immobilize arms and unaffected leg with sandbags. Abduct the affected limb into a lateral position. Immobilize the patient with tape or compression band. And make sure that the central ray is perpendicular to the mid limb. Have a good day.